Thank you for inviting me to contribute to this discussion on regional anaesthesia for caesareans. I want to start with a comment on the title for this session, in particular the words, "how to avoid getting sued." To be clear, I didn't sue anyone. I think it is important to remember that most people do not wish to complain or sue. But there is another important way in which our exam question misses the point, and I'm going to tell you what that is at the end. However, first, I'm going to share my experience of regional anaesthetic failure and what can be learned from it. I have two sons. The first was born naturally, and it was all very straightforward. But second time round, I had a low-lying placenta, and as it was an anterior placenta previa, it was made clear to me that this would be a higher risk delivery. I am grateful for having had life-saving surgery. However, because the spinal failed, I was able to feel major abdominal surgery, and that was every bit as horrific as you might imagine. Really, everything should have been fine. A consultant set up the spinal. He was very confident the block would be good. However, while the anaesthetic worked on my motor nerves, the effect was patchy with my sensory nerves. During testing, I struggled with one particular question, and unfortunately, the anaesthetist persisted in repeating that one test multiple times. I held my own for quite a long time, but felt under enormous pressure to give the go-ahead. There was a room full of people waiting. I was aware of the expectation that the block should be working. I was lying on my back, looking up into the face of someone who was convinced the block would be working. He was the expert, the person with authority. And that's a really difficult situation in which to go against authority. So despite real reservations, because I was not sure, I decided that a slight difference in sensation that I could feel must be sufficient. And I gave the go-ahead. I knew I had given the wrong answer when I felt the first incision. However, the anaesthetist was so certain that the block should be working, he was slow to recognize that it wasn't. The operation was stopped on 3 occasions, twice for me to be given alfentanil, and a third time to be given a general anesthetic. It was immensely traumatic because as a mother, my fear was focused on the safety of my child whilst enduring indescribable pain which I perceived as life-threatening. The experience was compounded afterwards when things were not handled well by the anaesthetist and the hospital trust. The anaesthetist of one of his colleagues visited me on the 3 days I was in hospital. Standing as far away from me as he could while still being in the room, he commented, "There is no accounting for science." And his colleague admitted they had no idea why spinals sometimes didn't work. But despite those verbal admissions, nobody on the ward knew. And when I was discharged, my family doctor received only the most basic discharge information, which gave details of a routine C-section under regional anaesthetic. When I mentioned the operation to my community midwife, there was nothing in my notes. So clearly thinking I was making a fuss about nothing, she told me, "Never mind, dear, the baby's all right. That's all that matters." Well, 10 months later, I went to my doctor because I was finding it very hard to engage with life. I felt I needed to understand what had happened. It was only when I told her that she learned I'd had a general anesthetic. She wrote to the hospital requesting an opportunity to go through my notes and received a letter back which stated I had been conscious and comfortable at the time of delivery. Obviously, had I been comfortable, there would have been no need for the general. My doctor replied, "Susanna does not want to make a formal complaint. She wants to offer constructive feedback so that future patients do not have a similar experience if such can be prevented." This resulted in what is called a non-apology from the anaesthetist, one where the emphasis of the wording effectively blames the patient for asking questions. My response to reading the letter was to be physically sick. I decided against the meeting because by then I did not believe that it would be positive. Now, my situation was not one where the outcome was catastrophic. I had a life-saving procedure and my son was all right. But because my notes did not reflect what had happened, there was no support. I developed post-traumatic stress, which has had a profound effect on me, and to be honest, the rest of my family too. Notably, I was so scared of going back into the same hospital that I delayed accepting medical intervention for my son when he needed it, something which seemed irrational at the time. Now, listening to my account, you will have realized there was no technical error. It came down to a failure to be prepared for failure, a failure of non-technical skills, and everything was compounded afterwards by the failure to respond appropriately. It was a year after my son was born that I started to try to understand how things could go so wrong. I discovered that there was no good data on how many blocks fail. I wasn't in a position to do an empirically robust piece of research. However, I created a survey to which 150 mothers contributed, many sharing experiences similar to mine, in their own words, highlighting the same difficulties I had identified. These women were anonymous and from all over the UK, and there were heartbreaking descriptions. For example, one mother who had a termination rather than face the same situation again. What struck me was how often patients had been expressing concerns, saying they were in pain, and yet the clinicians did not believe them and dismissed their pain. It was as if it was easier to doubt the patient than to question the block. They had a plan and they were following it. Not one of those women had raised a formal complaint. They were trying to get on with their lives, to work and to look after their children. Society tells us it is normal to suffer having children, and we should be grateful. It is hard to express the experience of trauma. Complaints will always be the tip of the iceberg. Remember, most people do not wish to complain. And it is absolutely crucial that we recognize that the most vulnerable patients are unlikely to have the knowledge and resources to access the legal route. Even so, litigation patterns have been providing clear evidence for a long time. In 2009, Anesthesia Journal published an analysis of litigation relating to inadequate anesthesia. The cases reviewed were from 12 years before that. The severity of reported harm after awareness under regional anesthesia was equivalent to that after awareness under general anesthesia. The authors commented that as regional anesthesia was considerably less frequent than general anesthesia, a similar prevalence of litigation indicated a notably higher instance of cases due to regional failure. 83% of these were in an obstetric setting, and most were due to surgery starting with an inadequate block. Now, of course, anaesthetists enjoy high levels of success with regional blocks, but every one of the estimated 2% of spinals which fails affects a real person, someone who deserves good care. And here's the key. Unlike complications which happen with little warning, block failure is one which can be, to a large extent, controlled for in advance by testing the block well. When I'm talking to trainees, I explain it's useful to remember why you test something. If someone could safely assume that when they place a spinal, it would always work, they would not need to test it. But spinals don't always work, and anaesthetists test because they cannot afford to make an assumption. There are a number of human factors which can lull someone into making mistakes here. The three most likely in my case were confirmation bias, fixation error, and continuation bias. Regarding confirmation bias, the weight of a clinician's experience will be towards successful blocks. It's natural to subconsciously look for things that confirm what you're expecting to see. So instead, rather than expecting to confirm that the block is working, you need to start with the assumption that the block is not working until you can prove that it is. My understanding from patients who have had both good blocks and bad blocks is that they found testing easy when it was a good block. So if a patient seems unsure, that may be a warning sign of a suboptimal block. Fixation error is basically saying, it's odd this isn't working, but I'm sure it will. I'll keep trying until it does. You can see how that goes wrong. And continuation bias, I'm going to come back to in a bit. The important point is that these potential errors can be countered with active listening. Without listening, clinicians lose a vital source of information, whether from the patient themselves, their birth partners, or other healthcare professionals. Hearing what is said and how contributes to clinicians' situational awareness, and it is key for patient safety. For a long time after my C-section, I kept coming back to one question, which was how could I have allowed an operation to start when I was not sure the block was working? It was unthinkable, and yet that was what I had done. What on earth was going on? Well, from a patient perspective, you are not yourself. Walk into a hospital and put on an operating gown and you become a patient. You have to entrust your well-being to the healthcare professionals looking after you. With an awareness of human factors, we acknowledge the hierarchy gradient in the operating theatre. However, the patient feels it too. They are not an equal in terms of skill and knowledge, and physically, they are in a deeply subservient position. I have often commented that as they stand over a patient, medics need to appreciate the extent to which their position, both metaphorically and physically, will influence that patient. Moreover, the patient isn't trained to be a good patient. In fact, they think they're being good when they keep quiet. To be assertive in such a situation does not come naturally. And even patients who are clinicians comment on this. For example, after an emergency C-section, one consultant anaesthetist wrote, "Your story helped me stick to my guns about my own inadequate block, despite having great concerns for my own baby's welfare." At the best of times, patients are prone to suggestibility. However, suggestibility increases when patients are highly anxious, distressed, or in pain. Unless questioning is carried out in a neutral way, patients' responses are likely to become misleading. It's easy to understand why patients place such a great value on communication. It is communication which allows them to orientate themselves in an unfamiliar situation. It helps them to feel safe. There's a lot of research showing effective communication improves rapport, and it functions as the basis for improving patients' comfort and their perceived sense of control. Good communication has been demonstrated to improve health outcomes, patient satisfaction, to reduce error, misunderstandings, distress, and negligence claims. Good communication enables patients to speak up. It can be difficult to articulate what makes good communication, but I think most of us know it when we hear it. For example, a dentist preparing to fix some metalwork in my son's mouth said, "I need you to tell me if it hurts because you're the only one who knows." So simple. It bears noting that while the words themselves are incredibly important, communication is not only about words. Tone, posture, eye contact, they all matter too. I said I'd come back to continuation bias. Continuation bias comes from the natural hope that everything will be okay if you stick to your original plan. An easy example is someone driving while tired, telling themselves they'll be okay, and not stopping for a break, only to find themselves drifting lanes minutes later. With spinal blocks, there's no point testing if you're not able to identify and respond to a poor block. I think it's helpful to remember that this is not personal. You're testing the block, not your block. If an operation starts with an inadequate block, it's likely to become traumatic for the patient very quickly. As I said, the pain I experienced was perceived as life-threatening. Interestingly, when I wrote about my experience for IJOA 6 years after the event, I was not yet able to articulate that. So I wrote, "Lying open on an operating table, I was not in the best position to make the best decisions for myself." which was true. It was the classic freeze, fight, flight response. And we know that in such situations, the frontal cortex goes offline, impairing an individual's ability to think straight and make decisions. I'm not condoning paternalism, but I do think that it is right that the Montgomery ruling in the UK allows doctors to advise on the best course of action in circumstances where capacity may be diminished. The problem for clinicians is not knowing just how patchy the block is, nor how extreme the pain. But as McCaffrey wrote, pain is whatever the person experiencing it says it is. So if a woman says she's in pain, believe her. She is the only one who knows. You may think she's safe, but believe me, if she's feeling pain during a C-section, she may not feel safe. For a patient, feeling heard and believed is an important mitigating factor in reducing the experience of trauma. So, regardless of what has gone before, how good the block seemed to be, how sure someone is that they tested it well, a change of plan is needed. It is all about being prepared. When I started speaking about my experience, it was never going to change the outcome for me. I did it because I feared for those who might be more vulnerable than I had been. Girls who were too young, women from minority groups for whom English isn't their first language, women who'd experienced rape or abuse. My concerns are borne out by data from Embrace in the UK. These groups are overrepresented when it comes to poor outcomes. Patients come with their past experiences, and should they experience trauma in healthcare, they will carry that with them. And that can then affect their willingness to access healthcare in the future, both for themselves and their families. The reason I have continued to speak has been because I have felt responsible for every mother I have failed by not ensuring learning happened fast enough for them. I found I needed to keep going until there was guidance in place. I believed that guidance needed to cover three things: a minimum standard for testing, management of breakthrough pain, and how to follow up afterwards. This last point is about ensuring that patients get the continuity of care they deserve. It is the right thing to do, especially now that we have an increased understanding of post-traumatic stress, and there is compelling evidence for the impact of maternal mental health on infants. After a long gestation, guidance along these lines has been accepted for publication by Anesthesia, subject to changes. Nothing gets past review first time. The guidance is really about anticipating the risk of a block not working and having strategies in place for managing that adverse event. Paraphrasing Tim Cook and Chris Frerk's work on airway management, a plan suggests a single approach. A strategy is a coordinated, logical sequence of plans. Anaesthetists should approach with strategies rather than plans. Finishing off, I want to explain why the exam question today misses the point. Because it underestimates you, the audience, our clinicians. After the first two conferences I spoke at for the Obstetric Anaesthetists Association in 2015, I asked if we could survey the anaesthetists who had been present. I wanted to gauge whether any impact remained, and after 18 months, a little over half had in some way refined their practice. 70% had refined what they told their trainees. I had spoken a lot about listening, and people had listened. On one level, I identified issues which made people reflect on their practice. But on another level, I believe that my experience resonated simply because clinicians care about their patients. My observation is that despite working under unrelenting pressure, clinicians care deeply about providing good, safe care. The vast majority have the humanity to aim for better outcome measures than simply hoping to avoid being sued. Of all the people in an operating theatre, the obstetric anaesthetist may be the only person whose sole focus is on the mother. For me, they are the guardians of mother's psychological well-being. I hope that my experience will help you as much as your patients. Thank you.